Okay, I think I'll make a start now. So again, welcome to everybody that's joined us for the first short webinar of 2021 and the first recording. Sorry, we're going to record this as well, so we will have this on record for people that want to watch later or people that don't have access. Your microphone is going to be muted throughout the whole of the webinar, and we are going to have a question and answer session at the end of the 40-minute presentation. Please pop your questions in the Q&A box. There's no chat facility on this call, so please pop your questions in there. We will endeavour to answer all of the questions either live on the screen or through the Q&A box. If anyone does have a question that we don't get around to answering, I'm very sorry. Please, you can email us to the SHOT office. The session will finish with a poll to give us some feedback for the webinar. So first of all, I'll introduce myself. I'm Cy Carter-Graham. I'm the SHOT Clinical Incident Specialist. And on the panel today, we have a few people from the SHOT team. So first of all, we've got Dr. Shruthi Narayan, who is our SHOT Medical Director. We have Jenny Davis on the panel, who is our SHOT Operations Manager. Vicky Tuckley, who is our laboratory specialist. And Fahim Ahmed, who is our SHOT Administrator. So what I'll introduce you now to Paula Bolton-Maggs. A lot of people may have heard of Paula. I've seen her in a lot of reports and things. So she's going to do a presentation on avoidable, delayed and over transfusions. Like I said, we'll take about 40 minutes and we'll have questions at the end. So Dr. Paula Bolton-Maggs is an honorary senior lecturer at the University of Manchester, and she was the former medical director of SHOT. She trained at both Cambridge and Oxford universities and has been a consultant haematologist since 1991, initially as a paediatric haematologist at Alder Hey in Liverpool, Children's Hospital Liverpool, and then as a consultant in adult hemostasis and thrombosis at Manchester Royal Infirmary. In 2011, she took up her appointment as medical director of SHOT. She's had a long-standing interest in both hemostasis and transfusion and has contributed to several National British Society for Haematology guidelines, and most recently the revised guidelines for irradiated components. She retired from her post at SHOT at the end of August 2018, but remains actively involved in the SHOT Working Expert Group and continues to analyse cases reported in this category, avoidable, delayed and over or under transfuse. So I'll hand you over to Paula for the presentation. Thank you.
Thanks. Thanks very much, Cy, for that introduction. So we'll proceed, and the category is called ADU, but I'm going to deal with it in a slightly different order because the most serious problems arise from delayed transfusions, and then I'll move on to the other ones. You can see that in 2019, there was a total of 279 cases, and most of those were reports of delayed transfusions with an increase from previous years. So the definition of a delayed transfusion is where a blood unit of blood or blood component was clinically indicated but wasn't undertaken at all, or was significantly delayed, or the components weren't available and there was a delay in transfusion with impact on patient care. And we haven't just assumed that this would be emergency transfusion. It would include, for example, where platelets weren't available and the patient had to come back the next day. So you can see that the reports have increased year on year. We began collecting these reports in 2010 because the National Patient Safety Agency produced a rapid response report because they had received several reports where patients had died or suffered serious harm as a result of delayed transfusion. So they made a number of recommendations for hospitals, including that they should report to SHOT, but also that they should review their major hemorrhage protocols and audit what was happening and things of that sort. So why is this important? Well, you can see from the data collected between 2010 to 2018 that delayed transfusion was responsible for 39 deaths, and that's a quarter of all the deaths. The other large component, you'll not be surprised to note, was pulmonary complications. But it's tragic that 39 people died as a consequence of delayed transfusion. So we'll have a bit more of a look at that. If we look at the data for 2019 and the preventable deaths, 5 out of 17 were considered to be preventable, and that includes a patient who was under-transfused, a person who didn't get PCC in a timely manner, and 2 cases of delay. So 4 out of 5 of the preventable deaths were in this category of ADU, and the other one was transfusion-associated circulatory overload. So the first point I want to make is that gastrointestinal bleeding can be very treacherous, with every second counting. The diagnosis is often delayed or missed when the bleeding is not visible, because you can lose a lot of blood into 22 feet of gut. It's also very difficult to estimate the amount of bleeding, and it may be overlooked because the patient's actually been admitted with something else, like a chest infection, and they develop maybe occult bleeding while they're in hospital. So this is just an example of a death related to delayed transfusion in an elderly man, and his clinical reviews and transfusions for one reason and another were repeatedly delayed. There was poor recognition of ongoing bleeding, and there were several transfers between different departments, and this is a common feature. A patient may come into the emergency department, go to the medical admissions unit, and then be transferred to a ward, with people being reluctant to start transfusion while the transfer is going on. This gentleman remained with a hemoglobin of less than 60 for 17 hours, and then he had a cardiac arrest and died due to hemorrhage. This is another example with the clock running. An elderly man was admitted at nearly 9 o'clock in the morning with GI bleeding. He had a low blood pressure and was dizzy, so he had symptoms, and he had a raised early warning score, which should have prompted urgent review. He was on warfarin with an INR of 7 and received PCC, prothrombin complex concentrates, in a timely manner. And at 10:15 or thereabouts, 2 units of blood were requested. They were ready at midday, but they were never prescribed or given. And at 2:30, 5.5 hours from admission, he sustained a cardiac arrest and died. So one point to notice is that the delays often are cumulative or multiply because of transfers and multiple teams being involved. And in this situation of bleeding, every minute counts, and it's really important that people act in a prompt manner with patients like this. Here's another case where delayed transfusion contributed to death. This patient arrived in the middle of the night after a 999 call by his friends. He was non-English speaking and had a history of alcohol dependence and hepatitis C and drug misuse. He wasn't triaged appropriately. The ambulance records noted that he was vomiting blood with a tachycardia and hypotensive. He wasn't monitored adequately. He should have had hourly observations and an early warning score. And he should also, with those characteristics, have been seen within 10 minutes, but wasn't seen for an hour and a half. Just over an hour later, the hemoglobin was noted to be 56. The laboratory contacted the emergency department and offered them OD negative blood, but they declined that and preferred fully cross-matched red cells, but this as a routine. And the patient's clinical deterioration was not detected in the emergency department by the nursing or clinical staff, and the major hemorrhage protocol wasn't activated, and the patient died at about 8:05 following a cardiac arrest with a further large hematemesis and melena without having received any blood components. So that's 4.5 hours from admission with a man who clearly had hypotension and tachycardia on admission. It may contribute to major morbidity, and here's a man in his 50s who was undergoing endoscopy and had chest pain due to a myocardial infarction, and the hemoglobin was 43 at 10:45, and he had a previous history of GI bleeding, which is why he was in endoscopy. At 1:30, red cells were available for collection but weren't transfused for another considerable time and more than 5.5 hours from admission. It's not clear why there was a delay, but I suspect inadequate communication was a contributory factor, and he was probably being moved between departments as well. He was admitted to the intensive care unit and he did make a full recovery. So major hemorrhage continues to be a problem, and we've analysed the major hemorrhage reports of delayed transfusion in some detail, and I'll come on to that in a minute. But that rapid response report that I mentioned to you that was published in 2010 had a number of recommendations about how to activate the procedure, to have the protocol, to make sure the laboratory has the correct patient details, to make sure that porters are available, and to check the communication channels with phones and bleeps. Hospitals are absolutely encouraged to run drills, and the fact is that if you don't have many major hemorrhage protocols or activations, that's the very hospital that needs to make sure that it does have a drill so that it works smoothly with all the parts working when it's needed to do so. So here, Sai is going to talk through the next two cases.
Okay, so this is a man in his 80s who went to the emergency department with a massive hemorrhage, and the MHP was activated correctly at the time. Emergency OD negative units and pre-thawed FFP were available and issued for use by the labs in a very timely manner. Paula, if you just go on. The blood components were available to collect, but the clinical staff were not aware of this. And about 20 minutes later, a doctor contacted the laboratory again just to find out if the components had been issued. The patient was transferred to the radiology department, but the components were then delivered to the emergency department. As Paula was saying about transfers between departments is an issue sometimes. And very sadly, the patient died later that same day. And then this is another case where a woman in her 20s had a postpartum hemorrhage, leading to an MHP activation. So again, the MHP was activated. Unfortunately, the midwife gave the wrong patient details to the lab staff, and it wasn't realised until the red cells arrived in the maternity unit and they identified the fact they were ABO incompatible red cells. They were returned and the correct details applied, but this resulted in a 25-minute delay to provision for this Group O patient. And that just sort of highlights the fact that we need to try and get it right first time with drills and with exercises. Thanks, Paula.
Thanks, Sai. So a half an hour delay may be absolutely critical in a patient that's having a very brisk hemorrhage. So we looked, as I mentioned, at 16 cases of delay in major hemorrhage, and these are the factors that we can show you that communication by and large, by far, was the most important factor, and then failure to follow the protocol properly, porter availability in some, staff shortages, poor knowledge, equipment, which includes things like the theatre fridge being out of action or the plasma thaw not working or a printer failure. And then people make assumptions, and sometimes they don't send the right sample, or they send one that hasn't been correctly labelled. So we put together a sort of map of these factors that we could identify in 34 cases of delays. And you'll see at the bottom of the slide here that, first of all, you have to decide to make a hemorrhage call, and that may not be as easy as it looks. Sometimes it can be difficult to recognise when a patient's having a major hemorrhage. And then when the laboratories have been alerted, they need to know the patient's group, they may need to set it up for an antibody screen, but anyway, they'll need to prepare and issue components, whether that's a major hemorrhage pack or what. Then the components have to be transported to where they're needed, so it's important that people know where the patient is. And then they need to be received and transfused. And of course, for that, you need venous access. And sometimes there's a delay because there's no venous access. So if we look at communication, first of all, you can see here that there were 30 instances where we could identify that. And these were the sort of communication failures, failure to keep the laboratory staff updated. And that includes making sure that the laboratory staff know when the activation is finished. Sometimes the laboratory staff don't understand the urgency of the request, and so it's important that there's a very good telephone conversation. Sometimes the laboratory staff haven't followed the advice of the clinical staff, or as I mentioned before, they don't provide the location because the location of the patient may be moving. And there's sometimes miscommunication between the different clinicians. So failure to follow the pathway properly, 16 cases, the wrong method used for activation. So switchboard think that it's a cardiac arrest rather than a major hemorrhage. Lack of knowledge of how it's activated, don't know where to find it, miscommunication between clinicians and so on. And we look at the underneath of this diagram, hemorrhage call, laboratory and so on. We can see that there were 2 sample errors. One, the sample was in the wrong tube or it was too small. Staff shortages are a real issue, and if a member of staff is lone working in the laboratory, that can be very difficult if they're trying to do several things at the same time. Wrong assumptions. The clinical and laboratory staff may each assume that the other has organised the porter, so there needs to be a clear protocol for what happens in a major hemorrhage. There were IT or machine issues, as I mentioned, the refrigerator's not working, software flaw in the limbs, pages not working. Sometimes the clinical staff can't contact the laboratory person because the bleeps failed, and there were issues with printing. Lack of knowledge. There's certainly been lack of knowledge in recognition of bleeding, so failure to transfuse an actively bleeding patient. And there have been issues about the laboratory knowing what group of platelets to provide. So there are lots of ways in which it can be delayed. And in fact, anywhere where there's a human interaction has the potential for an error to be made. So this is another case of GI hemorrhage, and if you haven't got the message already, you probably will have by the end, that gastrointestinal hemorrhage is a dangerous condition because it's often not recognised rapidly enough. And this man, as you see, presented with a 2-day history of leg pain, but was found to have a very low hemoglobin of 49. He had a lot of multiple comorbidities. Angiodysplasia, of course, predisposes people to GI bleeding. He had ischemic heart disease and stents, so he was on aspirin and rivaroxaban, excuse me. So blood was requested, but then you see the first sample was rejected because the date of birth was wrong. So there's already quite a big delay in this man with a very low hemoglobin. The plan then at nearly 2 o'clock was to transfuse to a hemoglobin of 90 cautiously because there was a high risk of transfusion-associated circulatory overload. But in fact, and I don't know all the reasons for this, the patient was not transfused until the following day when he was found collapsed with a hemoglobin of 34. Then he did get a very prompt transfusion of 4 units of red cells, 3 of FFP, and was admitted to ITU, but sadly, he died 24 hours after admission from cardiogenic shock related to this profound anemia. Every minute counts. Another important case that we had last year was a delayed diagnosis of severe haemophilia. And having worked in hemostasis for many years, I know that clinicians don't understand coagulation tests. And a key message for this case was that isolated prolongation of the activated partial thromboplastin time in a male infant is absolutely characteristic of haemophilia. And it's really important when that happens, either in the laboratory or when the clinicians get the report, to talk to a hematologist. So this was a boy less than 6 months of age who was seen in hospital initially because his mother fell with him in her arms, and he was fine. No abnormality was found. However, he presented 6 days later with a collapse, and a CT scan showed extensive intracranial bleeding. He then had 2 coagulation screens at that first hospital with an APCT that basically didn't clot, but a normal prothrombin time. He was transferred to another hospital where the coagulation tests were repeated twice with the same results. He was on intensive care, pediatric intensive care. And of course, a lot of abnormal coagulation happens in intensive care, but not one usually with these characteristics. So the results weren't discussed with the hematologists until 24 hours later. And this is the typical finding of severe haemophilia, which was then diagnosed by a factor VIII assay. However, that his death was related to the AV malformation, and they did not think that the failure to diagnose the haemophilia had contributed to that. But it's really important to discuss, if you don't understand abnormal coagulation results, pick up the phone, talk to a hematologist. And this is a simple guide really to coagulation tests. The boxes represent what's tested by the different tests. So if you have a prothrombin time, it looks at everything in this red box, tissue factor, factor VII, the combined pathway right down to the clot. The activated partial thromboplastin time looks at everything in the blue box. So 8, 9, 11, and 12, and the common pathway. The thrombin time only looks, or the fibrinogen level tells you about this part of the pathway. So if you have an isolated very prolonged APCT with a normal prothrombin time, which tells you the rest of the pathway is working perfectly well, it's got to be a deficiency of one of these 4 factors: haemophilia A, haemophilia B, factor IX deficiency, and The others don't matter so much, particularly factor 12, but it's an indication for urgent investigation and factor levels. And that should be part of a reflex pathway within the coagulation laboratory. At least pick up the phone and talk to a haematologist. So we recommended a couple of things in the last year's report. All hospitals should regularly review their major hemorrhage procedures to ensure that communication lines are good, and they should practice with drills. That's some of the advice in that rapid response report from 2010. And then laboratory tests of hemostasis must be interpreted, obviously, in the context of clinical findings, as well as other laboratory test results. Appropriate timely actions are essential because they may be potentially life-saving for patients with unexplained bleeding. So this is an action for transfusion teams, consultant hematologists, and laboratory managers. So now I'm going to move on to avoidable transfusions. The definition of this is it's where the intended transfusion is carried out and the blood component is suitable, but the decision leading to the transfusion is flawed. And it's important to notice that avoidable transfusions may result in transfusion-associated circulatory overload. And so in short, if that happens, those cases will be reported to the Takehome group and cross-checked probably with avoidable transfusions. The first thing I want to talk about is avoidable use of group OD negative red cells. And there were 31 cases in 2019. In 10 cases, there were cross-matched units already available. 5 cases where the patient could have received group-specific units. And there were 5 cases where there were delays because of earlier errors. So they had to use D negative because there were sample labeling errors and so on. But what was particularly interesting to me is that 23 of these 31 were men or women over 50 years of age. And these are the 2 groups of patients that can receive OD positive red cells. And that would be sparing on our supplies of D negative. That excludes, of course, patients who are already transfusion dependent. So if you have a man with MDS who's getting regular transfusion, who needs an emergency, that they would get OD negative. So if you haven't done so already, do check out the National Blood Transfusion Committee guidelines and make sure they're incorporated into your hospital procedures. And you can find them on the transfusion guidelines part of the website. So hospitals should use the available toolkit, and their transfusion policies should reflect that OD positive units can be used in older women and men. It's frustrating to see that iron, folate or B12 deficiency is still treated by transfusion when it's not necessary. In fact, it may be dangerous. And we reported last year, I think it was in the Takehome chapter, a case where a patient with severe iron deficiency was compromised by having an unnecessary transfusion. And we know that it's potentially dangerous in people with very low hemoglobins with B12 deficiency because the heart muscle is also B12 deficient. There are now choosing wisely recommendations about avoiding unnecessary transfusion, and you can find them on the website of the Royal College of Pathologists. So avoidable transfusions were given to 6 women with iron deficiency and 3 with B12 and or folate deficiency. And the clue is there in looking at the mean cell volume of the red cells, because if it's B12 or folate deficiency, the MCV will be considerably raised, maybe 110 or even 120 instead of around 90. And in iron deficiency, the MCV will be very low, maybe 57, 60. So there's a big clue when you look at the hemoglobin to look at the MCV result as well. So we think medical staff need better education about anemia. They're not getting taught it very much these days in medical school. And senior doctors may not know this either. And it's a pity when a patient gets a transfusion that they don't need. It is indicated a transfusion maybe when an elderly patient has serious symptoms, then maybe a single unit. And GPs can help us out with this by understanding themselves and managing iron deficiency, particularly in the community. So the transfusion-related choosing wisely recommendations should be widely promoted, and patients should be encouraged to discuss whether their transfusion is appropriate as well. Avoidable platelet transfusions were received by 16 people, and every year we see a number of cases where the cause of the apparent thrombocytopenia is because the platelets clump due to the EDTA anticoagulant in the tube. So it looks on the counter as if they've got very low counts, but if a film is spread and looked at under the microscope, then you can see the clumps and then you know that it's spurious. And laboratory practice should be, when you have an unexpected low platelet count, to make a blood film and have a look to check. Also, even if it's not due to platelet clumping, one should always say, well, why has this patient got thrombocytopenia? What is the diagnosis? Because, for example, it wouldn't be appropriate to transfuse platelets if the patient's got immune thrombocytopenia. So the diagnosis should be considered for a low platelet count rather than reaching for the platelet transfusion. So prescription for avoidable red cell transfusion based on the wrong hemoglobin results, 27. So results from other patients, wrong blood in tube. Results from blood gas analyzers, which are either misinterpreted or the analyzer is not quality assured of hemoglobin measurements, and not all blood gas analyzers are. The NEQUAS did an exercise in 2011 to demonstrate whether it was reasonable to use blood gas analyzers for hemoglobin measurements, and their conclusion was that they absolutely need to be quality assured before you can use them for that means. And I think they now run a scheme to make sure that you can check whether it's accurate. And then we quite often see dilute samples taken from the arm where there's IV fluids running, so you're not getting a genuine hemoglobin level. And then we have plasma and cryoprecipitate transfusions that could have been avoided, 6. Fresh frozen plasma is actually very, very infrequently really required. And there are a number of cases that we see where it's inappropriate for the procedure, or clinicians are giving it at a level of INR or prothrombin time that really doesn't require correction. And it's unfortunate that people use FFP so often. In fact, there's no real guidelines for what dose should be used. If you read the most recent FFP guidelines, we looked in the literature and there isn't any evidence about how much you should give and whether you should give it. And I think it's very much an overprescribed component. This is an example of erroneous reading from blood gas analyzers. And these complicated printouts is what you might be presented with for all your blood gases. But down here at the bottom on the co-oximetry, you can see that there is THB, which is the total hemoglobin level. And then there's a whole list of other sorts of hemoglobin. And one year we had a person being transfused on the basis of this result, which is nothing to do with the total hemoglobin. And then on this one, they selected a different type of hemoglobin. So if you're using those kind of reports on which to base your transfusion, please make sure that you understand what you're looking at and you look at the right level, which in both these cases was a level at which you wouldn't normally transfuse. So key short messages from the avoidable transfusions is that group D negative units are being used when D positive could be used in more than half the cases. Poor communication results in avoidable use of D negative units when cross-matched or group-specific units are available. Hematinic deficiencies continue to be poorly recognised and managed inappropriately, and that's because of poor education, I guess. It's really important, and this crops up again and again in all the shock categories, to take time to identify the patients, or particularly to get the patients to identify themselves. So you know you've got the right identification, and the sample must be labelled absolutely correctly. You'd be surprised by the number of patients who have the same names or the same or similar dates of birth or the same or very similar identification numbers. You must be very careful. It's safer to do that, and it avoids the need for repeat blood samples. We had a patient, I think it was last year or the year before, an elderly woman who ended up having her blood taken 7 times before she had 2 acceptable samples in the laboratory for blood grouping. That's actually unkind. So hospitals should review their use of O negative. and use them according to guidelines, and they should look and promote the choosing wisely recommendations related to transfusion. And more recently, there's the NHS commissioning sequence safety indicators for preoperative anemia prior to major surgery. And we've been very pleased this year that restrictive transfusion, based on some of those choosing wisely guidelines, is now part of the new evidence-based interventions published by the Academy of Medical Royal Colleges at the end of last year. At the bottom, if you can see it, is the website to find the choosing wisely recommendations that were published from the Royal College of Pathologists. I think there are 5, but they're about the sort of sensible things of avoiding transfusing patients with iron deficiency and so on. We can improve our practice in that area, I think. So let's look now at under or over transfusion, both dangerous. Number 35. So what's the definition? It's a dose or rate that's inappropriate for the patient's needs, excluding those cases which lead to TACO. Infusion pump errors leading to under or over transfusion. But if those errors didn't lead to over or under transfusion, those can be reported through the handling and storage errors group. So children feature largely every year in this group. So there were 30 out of 35 cases were over transfusions, and 11 of those 30 were children between the ages of 13 days to 14 years, mostly because of errors with calculation of the volumes or wrong settings of pumps. And particularly where children are being prescribed components by non-paediatricians, they're more likely to have errors. There were also 2 children on regular transfusion, and the parents noticed the inappropriate volumes. So that is likely to be children, for example, who are being regularly transfused for sickle cell disease or thalassemia. So the parents get used to the sort of volumes that their children are receiving. There's another reason for over or under transfusion, and that's lack of knowledge of components, particularly cryoprecipitate. And sadly, there was one death related to under transfusion during surgery because the patient had major hemorrhage and they didn't recognize really how bad it was and didn't give her, I think it was, enough components. So volume calculation of blood components in children continues every year to be of concern. And we wish that laboratory scientists could be empowered to question inappropriate requests, and that is difficult. But laboratory scientists know a great deal, and they can often recognize when it doesn't look right. Point of care testing should be set up collaboratively with laboratory support, using agreed protocols and standardization. And there is national quality assurance programs, for example, for point of care testing, both for blood gas analyzers and thromboelastography. Correct cryoprecipitate dosing is important. That is used for replacement of fibrinogen. The dose needs to be correct. And in 2006, the way of prescribing or the way of sourcing cryoprecipitate changed from single donor units to pools of 5. And even as late as last year, some clinicians were prescribing 10 units of cryoprecipitate, meaning single donor units, and the laboratory supplied 10 5-donor pools, and that's what I call overtransfusion. But that's a sort of request really that a laboratory member of staff should challenge, because you wouldn't really give more than 2 pools of 5 to anybody. So all medical staff, including consultants who prescribe or authorize blood components, must receive transfusion training in order to recognize components, their indications, and appropriate volumes. And I have the feeling that mandatory transfusion training is slipping a bit in hospitals because there are so many other things that they have to know how to do. So the other category that's in ADU that doesn't have its own, maybe we should add up prothrombin complex concentrates. Obviously, we don't manage to collect all the things that go wrong with this, but we do learn lessons from the few that are reported. And there were 16 in 2019. 11 of these were delayed administration, and 4 of those were in patients with intracranial hemorrhage. So we asked reporters to report any issue with prescription and administration of PCC. We don't want things like allergic reactions, those should be reported through the yellow card scheme. But the key shot message here is that serious bleeding, and it's usually patients on warfarin, puts their lives at risk. Rapid assessment is required. Vitamin K should be given, and PCC, but these should be administered within an hour and before the patient's transferred between departments or wards, because we've seen that delay is quite often because of the transfer between wards, or it's because the clinicians don't know how to administer the product. And one patient with intracranial hemorrhage died related to a delay in getting the PCC on that occasion. So common features, lack of knowledge, and it's not used very often, and so people don't know how to use it. They think a hematologist should come and give it, but they couldn't do that. And in any case, the instructions in the boxes are entirely clear. As I've mentioned, delays are certainly due to miscommunication between the emergency department and destination ward, and we saw that in 5 patients with serious bleeding, with the delays ranging from 2.5 to, astonishingly, 24 hours. A patient with an intracranial hemorrhage didn't receive PCC for 10 hours, and the hospital policy was changed as a result. Where intracranial hemorrhage is suspected in a patient on warfarin, you can give 1,000 units stat without waiting for the INR before the CT scan, because that won't be too much and it may well be enough to save the patient. So hospital policies should ensure that this treatment is given within 60 minutes. And teaching about PCC, we've put here training for all staff, but certainly staff within emergency departments where these patients are likely to be admitted in the first instance. So I'm at the end now, and I think the take-home messages that I would recommend to you, first of all, communication, communication, communication. Try not to have mixed messages, make assumptions, write down the wrong results. The second thing is that I think haematology knowledge is generally weak. I think people know less haematology now than they did 15 years ago, and that's to do with education in medical schools and probably in junior doctor training. I've mentioned my concern about transfusion training, whether that's slipping because there's so much other mandatory training to do. And then I think gastrointestinal hemorrhage is very alarming, that we have reports every year, patients who come to grief because that hasn't been recognised, or it hasn't been recognised quickly enough, or it's occurred while the patient's in hospital with a different complaint and they're put on anti-inflammatory agents that help them to bleed. So thank you very much for your attention. I hope that's been useful, and we'll pick up now any questions, I think.
Perfect. Thank you so much, Paula. And that was really informative, and hopefully some really important information is going to be taken from that. So we're just going to go through the Q&A questions now. For you viewers, I'd really ask for your help in upvoting, so pressing the little thumbs up button next to the questions that you really want to be answered, and that helps us prioritise the questions that we want to look at. So Jenny Davis is going to come and help me field some questions. So have you got a question there, Jenny?
Yes, thank you. And thanks to everybody for putting the questions through. There's some really great questions coming. The first one is about drills. So which teams should be involved in MHP drills, and how often should the MHP drills be run? So
any clinical team dealing with major hemorrhage is the answer to that. So that would certainly include casualty staff. And probably acute medical staff as well, and surgeons and anaesthetists. And I would have thought, I'm just looking to see whether there's anything in the rapid response report to tell us how often, but we used to run emergency drills for big event crashes and stuff like that, probably once a year in a hospital, because it's something that you need to be refreshed about. And maybe Shruti's got an idea about that too. I'll have a look in here.
Did you have anything to add, Shruti?
Yeah, sorry, my IT issues were actually playing up and my computer had frozen up. Sorry about that. So I think the question was about who all need to be involved in the MHP drills. And I think it is actually, that is one of the points that we actually realized is when we deliver the education sessions, it is usually in professional groups, but there is not, but we deliver care in teams. So I think there has to be that team-based learning, interprofessional learning, and therefore that improves that safety culture, that improves that seamless communication between the teams. So ultimately, while the arrangements may be slightly different to each of the trust, it is important that have a mock situation of if a patient comes in with a MHP, then who are all the teams? So, say it is actually happening in an ED, or it could be obstetric hemorrhage, or it could be a patient on the ward who is having it. So I think being prepared for all the various scenarios, and then having that, who is having what responsibility, how is anybody taking up that leadership role, as well as, the communication role. So it is that clinical, laboratory, the liaison, and also having a debrief, because one of the other key messages for us was actually, even when you have both the simulation exercises as well as after an MHP event or any significant event, having that quick debrief to actually say what went well, what didn't work, what we need to improve. And that spending those 5 minutes itself is actually going to be helpful in learning as teams.
The other thing I would want to say is that it's quite important that hospitals review their major hemorrhage protocol activations on a regular basis, because they can learn lessons from doing that. And I think the Northwest region actually did an audit. They've done at least one audit of all the hospitals of the MHP activations, and found that quite a lot of them were related to GI hemorrhage, which I think wasn't what people originally thought. They thought they would be in casualty, or from, mass casualty or traffic accidents and that kind of thing. But a lot of them were that scary thing, GI hemorrhage.
Lovely, thank you both there. And I'm really glad from my lab perspective that Shruti mentioned lab there, because I think that's really important that all the teams are involved, and that helps the laboratory professionals have an idea what clinical colleagues are dealing with when they're calling a massive hemorrhage protocol. So thank you very much for that. Next question that we've got on the list is it appropriate to make a decision to transfuse based on point of care testing results in a symptomatic patient, or would you recommend following up with lab testing where that delay would not compromise care?
So my answer to that is that it may well be appropriate to do that, but it should be a point of care machine that's been quality assured as being reliable for haemoglobin, and it should be accompanied by a sample sent straight away to the lab to compare it with. But in an emergency, it's reasonable to transfuse on the basis of that result, but make sure you get the proper result back. But because we know there have been several instances where the blood gas machine hasn't given the right result, or as I showed you, they've read the wrong line.
Yeah, and I would just like to add to actually say, the urge should not be to normalize the numbers, and it is always important to actually look at the patient and treat the patient. And what we often see is all these avoidable transfusions is actually, take them just over to the safety limit. It is actually taking them beyond the tipping point. So therefore, the minimum transfusion that are actually necessary, and then review the patient. So hemovigilance and patient blood management will go hand in hand. It is like two sides of the same coin. So therefore, you need to look at the safety. Always actually make sure that you're making the right decision by weighing the risk as well as the benefit.
Yes, the other thing I want to say is that I think the most extraordinary case we had was a woman with hardly symptomatic or asymptomatic severe folate deficiency. So she had a low hemoglobin, low platelets, and a low white count, because they all go together. And the junior doctor who saw her panicked and put out an MHP call on her, and so she got red cells, platelets, and everything, FFP, that was completely inappropriate, which shows a huge lack of understanding in that junior doctor, actually, who should have escalated that and asked for help.
Okay, thank you. So the next question is, when is transfusion for IDA shot reportable?
Good question. When it's not an appropriate transfusion is the answer.
Yeah, and I do agree. I think all the clinical situations are going to be different, and they need to be individualized. And actually, there are several instances where we acknowledge that, as clinicians, there are no hard and fast, and there are many gray areas in the clinical practice. So I think what we are saying is actually, whenever there is a mismanagement, that the iron deficiency could have been actually picked up. And actually, everybody will agree that iron deficiency is a public health problem. So therefore, what we really need, and it goes through different stages, and we should be able to actually pick it up and advise, by treating even the underlying cause of the iron deficiency, as well as topping up with iron quite early on. So I think there is an element of public education, public health education, involvement with the primary care. But then for the transfusions, it is actually making that decision based on whether there is actually bleeding, whether there is cardiovascular compromise, or whether there is a sudden drop. Because if there is actually chronic nutritional deficiency, patients are much more well compensated. So I think, I would say, discuss with your local transfusion team, and there are no hard and fast rules, and it is actually a decision that we make based on all the factors that are available.
Lovely, thank you. So next one on the list is, can you use OD positive blood for a male under the age of 18 who is OD negative?
Thank you for raising that. In fact, I think that group's excluded. I think you'd have to check with what the NBTC came out with, but I think that you don't give it for males who are under 18. It's only older once they get, I don't know, when they're adults. But there is a cutoff.
Yes, and I think the link is there in, the link is there in Paula's slide, but if you go to the NBTC guidelines, they're all there and these scenarios are covered. Thank you.
Okay, thank you. So the next question is about complex patients. So how do you deal with a request for urgent transfusion in a patient with alloantibodies? So
there are a couple of things that have emerged from looking at these. The trouble with patients with alloantibodies is sometimes a local transfusion laboratory, if they know about those alloantibodies, may be able to select red cells that are appropriate for that patient. But I think what we've observed over several years is that the level of knowledge and expertise in transfusion laboratories has become less. The people who knew a lot of red cell serology have tended to now be retired. And so more requests are going out to the specialist laboratories. And of course, that adds time. And the most important thing is that the patient shouldn't bleed to death or die from anemia, so that it may be appropriate to have concessionary release of the best available red cell component for that patient.
Yeah, and just to add that, I think, always ask help from the colleagues as well. So there are transfusion colleagues in the blood services. So let's say, for example, PBM consultants in NHS, BTS and BTS. So in the respective blood services who would be able to actually support and also help in that supply chain to actually see what would be the next best component that can be given with very minimal delays. So I think that ultimately, I think keeping everybody in that loop, again, involved in communicating through that, good handover if there is actually, spanning two different periods of activity. I think all of these, again, back to fundamental principles.
I think the other important thing is that sometimes clinicians don't appreciate the importance when a report comes back to the ward with evidence of alloantibodies on it. And then if the transfusion laboratory have asked you for more samples, provide them promptly, because what you don't want is to find yourself 24 hours later needing blood in a hurry when some of that could have been avoided by doing the investigations and sending them out to the specialist laboratories. So, and in patients who are known to have antibodies, clinicians need to be very, very clear, so supposing they're coming in for surgery that wouldn't normally need red cells, but if they've got alloantibodies, you might say, well, I better have some available in case, since this patient's very difficult to get red cells for. So there are a number of levels, but the main thing is not to ignore the problem.
Lovely, thank you, Paula. Next question, interesting question. Now many hospitals are starting to use O-positive red cells for emergency issue. When would it be required to be reported to SHOT if they were used in the same situation as an avoidable use of O-negative blood? So persons concerned that the reporting criteria states O negative.
All I can say to that is, I think, hemovigilance is not like a stick. So we need to actually come back to saying that hemovigilance is used to actually improve and make improvements in our services. So it is, please don't view this as, okay, this is actually, something that we need to actually report to actually hold. It is more to actually look at areas for improvement. Now, while we are saying that, the reporting criteria are actually reviewed annually, with in keeping with what are the differences in the guidelines, having a scanning of the horizon and what should be the current practices. So depending on, so what's the space? So every year when we actually review this, if there is any addition that we need to do or any amendment, we would then be adapting that.
I'd just like to say, actually, I think Paula was very on the ball, and the definitions that have just come out in the past month from SHOT for this year, we've actually clarified our wording to say avoidable use of group O red cells. So hopefully that'll be nice
Thanks,
and clear
Vicky.
for you, so you can pass those on to your transfusion teams.
Okay, thank you. So the next question is, should PCC be available as emergency issue within ED? So
that's a very good question, and it depends, it varies a bit with the hospital, and it depends where it's kept, because you don't want to have to get it from pharmacy in the middle of the night if you can't. So I know a number of hospitals where they have got a supply in the emergency department, but then the worry is it being used appropriately? So I think it's going to vary with hospitals, but the most important thing is that it is available, and of course it needs to be accounted for because it's a blood product, so that the batch numbers need to be recorded against that patient in case, God forbid, there was some awful infection in the future. But I know some hospitals have gone down that road, particularly hospitals that have had bad experience. I don't know whether, Shruti, you've got general views on that.
No, I agree. I think it is. It's good. It should, anything that would prevent any delays in the administration, and I think more importantly for us is actually staff becoming familiar with it, so that we've also seen where the nursing staff would then be saying this is not something we should be giving, only medics should be giving, and then medics are not used to handling. So I think it's in that case it is actually the patient who needs it. Instruction leaflets and well in advance aware of what do we need to give, what are actually the indications, how should this be administered. So addressing these knowledge gaps.
Great, thank you. Next question, I'm going to apologise. I don't think we're going to answer it here because it's about the impact of COVID-19 on transfusion safety. But we are analysing that data, and it will be included in next year's SHOT report, but we just haven't ratified it yet and been able to evaluate it properly. So watch this space for the next SHOT report for that next question.
I think only thing that we can add is actually, at least there's no significant increase in the number of the reports that we have actually had, roughly around, I think, 4,000 reports that we have received in the last year. And we are currently looking at all these and the trends of the reporting. And I think we are very grateful that hemovigilance reporting has continued during this. And I think that is something that we need to acknowledge, despite all the challenges that everybody is actually facing, the importance of the value of that reporting plays in, improving the patient safety. So what we are looking at is how has it affected the trends of the reporting? Was there any difference in the patterns of the errors that we are actually seeing, especially when we have staff being actually redeployed? So we're also working with other PBM colleagues to actually come up with all the resources, and some of them have already been produced. So yes, as Vicky says, please do look at the 2020 report.
okay, so the next question is somebody's reporting that they're worried about the huge gaps in knowledge and lack of medical training for transfusion, which is noticeable when they train juniors. And the RTT has been discussing revisiting a transfusion medical training passport for staff to standardise basic knowledge. Do you think this is achievable?
So I can add to that. Thanks very much, Lydia. This is actually kind of the hot topic that we are going through as well. So two things I would like to add. One is I completely agree. I think the transfusion training is getting diluted, as Paula mentioned as well, and it is across board, so I think it's also losing the importance and the coverage of the topics that are actually needing to be delivered across through the medical schools, foundation schools. So there are a few things that we are actually doing, along with collaborating with other professional bodies like the Royal College of Pathologists, the NBTC, and the other groups as well. So first, we are writing to the GMC because GMC is coming out with a MLA, which is the Medical Licensing Agreement from 2023 that covers the undergraduate medical education, and we are highlighting the importance of covering the transfusion topics and what are the key areas, at least the minimum knowledge that they need. And second, we're also actually trying to work to say what is the minimum transfusion knowledge that is actually required based on what transfusion activity that is needed. So whether you're actually collecting the samples towards putting up the blood, or are you actually in the laboratory doing stuff. So I think we are working again with some of the local hospitals as well as with the other professionals involved in this. So it's a very collaborative effort. We're trying to actually provide a national guidance that can then help improve and reduce the variability in this region. I hope that answers, but it is still a lot of work needs to be done in this area. Thank you, Vicky.
That's okay. I was wondering whether Paula has anything to add. Don't worry. Lovely. Next question. I think we might have to make this the final question and a bit of a discussion because we're running up on time now. So next question is about communication with the clinical area. So they're having trouble getting the clinical area to report delays to the laboratory, who then report onto SHOT. And they'd only hear about incidents if there was some harm or that the laboratory were being implicated. and this is learning to giving opportunities for lessons to be missed. So how do we encourage that communication?
And no, I think it is only improving the awareness. And I think people should not think that the reporting should only happen if there is an element of blame or if there is an element of harm that is associated. Near misses need to be reported as well. And equally, I think, it is important because that unless the person in the hospital who is reporting to MHRA and SHOT are actually aware of that incident, then, reporting cannot take place. Even though we have close to 100% participation, we are aware that there are areas of underreporting. So even with these numbers, these numbers may not truly reflect everything that is happening. It just gives us a flavor of things. I think all that we would be doing is it is slowly chipping away, trying to actually make people, we have a good reporting culture, but we need to improve that reporting culture and improve that communication. So I think, in your trust as well, I think one of the gaps that we realized speaking to, different professional groups, people don't really know how the flow of the hemovigilance information comes through. So if a patient in a hospital is actually having a febrile reaction or an allergic reaction, how is that ultimately actually translating to a learning nationally? I think that is a piece that we need to actually work on, and even the local transfusion teams, the transfusion practitioners, and the laboratory transfusion managers would be invaluable in ensuring that we plug these gaps and understand the importance of this hemovigilance. Thank you.
Lovely. Okay, thank you so much for all your questions. There's been really great conversation that's been happening, and we'll just have to apologise that we won't be able to answer all of these questions after the session. But if you have a really burning desire and it's brought up a subject that you really want to know about, please email us at shot@nhsbt.nhs.uk and we'll do our best to get back to you on those. So what we're going to do for the last couple of minutes is just have a live poll about the session. And whilst that's up and you're all answering your questions, so there's a couple of questions there. If you select your answers and then when you go down to the bottom, press submit, that would be really good for and really useful for us developing these resources. So the first question is about how useful you found the session. Second one is just knowing where the spread of geographically people are watching the session. Third question about how many people are viewing on one device, and the fourth question about the staff group there. Oh, and we've got a fifth one, sorry, apologies, missed that one. And just seeing whether you enjoyed it and whether you'd recommend it to anybody else. So whilst you're taking a second to answer those, just to let you know, reiterate what Sai said, that we've been recording this session, so it'll be available on the website shortly after. And not just the Q&As, any questions you have, we're always very happy to hear from our reporters and anybody with any transfusion hemovigilance related queries. So get in touch with us and visit our website as well, which is shotuk.org. Lots of resources to help with your transfusion education. And you can also download the SHOT app now, which I think is being quite useful. So I think that kind of pulls it together from the poll point of view. Any final concluding comments for any more of the panel?
Yeah, I just want to say that, of course, O negative blood is not safe for everybody.
Perfect, thank you, Paula. Yes, that's a really good point. Yes.
And just two things I would like to add is actually please do download our SHOT app, and this is now freely available since the end of last year through both the Google as well as the iPhone, Apple platforms, and you would be able to access everything on our website on your smartphones as well. And also please watch the space under the current resources. The SHOT videos and the SHOT bites are regularly updated and we add to the resources, and feel free to use all of these resources in your local training and education. And if there are anything, also contact us and we would be endeavoring to help you in your queries.
Perfect.
Thanks very much. And a big thanks to even Michelle as well, who has been silently there and then helping us and providing the IT support as well. So thank you and have a good day, everyone.
Great. Thank you, everybody.
Bye.
Bye.